Thank you everyone for being here this morning. My name is Crystal Riley. I'm Deputy Director of Government Affairs and Healthcare Policy for Baxter Healthcare Corporation. And I am very, very pleased to be moderating this panel where we dive into diversity and inclusion and how it helps in the innovation of healthcare technologies. So when we think about diversity, what it is an acknowledgement that people are different, that they bring to the table their own unique backgrounds, experiences, and perspectives, but without inclusion, it doesn't mean a whole lot. It's the equivalent of inviting people to the table and having them sit with their hands in their lap, where the difference in making sure that there's some level of inclusion means that you're not only inviting those people to the table, but you're asking them to bring with them their signature dish. And being able to share those different ingredients, those spices, and bringing things together to create new ways of looking at things, to create new solutions to existing problems, is at the very core of innovation. And if we go a step further in looking at innovation itself, we can find that across all levels of healthcare, whether it's in the corporate structure, whether it's in the technology that's actually being created, and how we parse out those technologies and therapies to our target patient populations. So I have the immense honor of presenting to you an incredibly talented panel who is working in a myriad of spaces within healthcare to walk us through all of the ins and outs of D&I as it pertains to innovation and technology, how it's created, how it trickles down to patients, and how we can all work together to make sure it's impactful in the most positive way possible. So, to my immediate right, we have Mr. Jim Traficant, who is the Managing Director of Federal Health for Accenture. To his left, we have Dr. Tran, who is the Global Clinical Development Lead, Renal, for Baxter Healthcare. To her left, I'm sure you all are quite familiar, Dr. Gary Puckrein, who is the President and CEO of the National Minority Quality Forum. Beside him is Dr. C.K. Andrade, Director of Product Management for Philips. And last but certainly not least, we have Dr. Murray Abramson, VP of Global Affairs for Biogen. Please welcome our guests to the stage. So I'd like to invite our panelists to give a brief 6-minute overview of who you are and what brings you to this stage in the context of D&I and innovation. Jim, we'll start with you.
Thanks, Crystal. Good morning, everybody. I'm Jim Traficant. I serve at Accenture Federal and lead our work across a number of federal agencies, including with healthcare.gov and a lot of work with the Department of Defense and serving in the Department of Veterans Affairs and helping government to connect not only with each other but with the private sector where so much of that care occurs. I got into this field. My background is in aerospace. I'm an engineer by training. But life changed for me. We have a number of clinicians and experts in the previous panel and in this one. And I guess my reason for being here is because I'm a patient. I've had 2 liver transplants. The first one, my neighbor saved my life. We were the 5th to have the surgery at Hopkins, the first that weren't related. And in the course of my treatment, I came to appreciate that healthcare had lots of data. What they were missing was information. And the first transplant saved my life. The second one gave me my life back. And I went to the brink of death in between those 2 with an episode of septic shock. And so patients are willing to endure a lot to get a few more good days, and for me today is one of them. So I'm really grateful to be here. And, thank you. And then I look forward to, I've made it I'd say this is true for our family, sort of our life's calling. We went from things happening to you to maybe they happen for you. I went into healthcare to try to make a difference, connect the systems, and unlock the data so that when patients arrived for care, they could get the best care possible. And it didn't matter who you are, where you were from. but the data would show up when you did, and then we would get to better outcomes. So I look forward to engaging in the discussion.
Thank you. Dr. Tran?
Thank you. Good morning, everyone. Hi, my name is Tran, and I am the Global Clinical Development Lead at Baxter International. So what that means is that I oversee all of the company's clinical trials in renal care franchise. And to that degree, I also oversee the global evidence generation and all of the different products in that field. So Baxter is a very interesting company because it's a hybrid company. So we have a little bit of pharma, some medical devices, we do solutions and other hospital care products. By background, I'm a pediatric nephrologist, and what drove me to become a nephrologist is also very personal as well. So during medical school, my sister-in-law went into kidney failure and needed a kidney transplant. And you know, I was really interested in nephrology anyways, because there's a lot of numbers. You can't fake kidney disease. You either have it or you don't. So that was one of my, you know, incentives for going into nephrology. I'm also in academia, so I am on the adjunct faculty at Stanford School of Medicine. So I still, you know, do biopsies. I take call and I'm in the ICUs and whatnot. So that really helps me stay close to patients. Additionally, I am a clinical faculty mentor for the School of Bioengineering. So they go through the process of something called biodesign. And Baxter has partnered with Stanford through the biodesign process, where you really focus on the unmet needs, so unmet medical needs and unmet societal needs. And then you come up with their solutions for that based on that statement. And so I'm really happy to share like a couple of our innovative therapies that we have in development, and you know how the diversity in the workforce as well as in our research process goes into the product development stages. So for example, we just concluded a phase 3 randomized clinical trials in an entire new a new class of dialyzers. And I'm so proud to say that we had in that study population 186 patients, where 40% of the clinical trial participants were African American and about a quarter were Latin American. So we're very proud that our study population is representative of the treatment population.
Thank you, Ha. Dr. Puckrein?
Thank you. So I remember back in the sort of late 80s and 90s, we started speaking of the digital divide, and there the conversation was making sure that diverse populations had access to the internet, and still, we still struggle with that digital divide. But there's an actually really more profound divide that's emerging, and I'll call it the augmented intelligence, the AI divide. So all of you play with your cell phones and you go to Amazon and Google and Facebook, and what you don't recognize, or maybe you recognize and leave it at that, that in the background there's a lot of technology that's running that's profiling you, that you are being collected in a huge database, and then you are analyzed and clustered, and all of your buying patterns, your propensity to do X or Y is being collected and managed. There's no diversity in that, and the diversity I'm talking about is in the business side of it. And so all of that augmented intelligence is coming to medicine. If you go out to the radiologist's website, for example, you can see that machines are starting to make the diagnosis off of screening data and imaging data for radiologists. Our community is woefully behind. And the problem with this technology is that it ain't catching up. You're not going to catch up easily. And it's hard because it takes big data. It takes real skill sets in order to analyze that data. And we've already seen all kinds of bad implications where the people who are doing the programming and the development are not diverse. So what we've been doing at the National Minority Quality Forum, for those of you who don't know, we've been collecting health data actually since 1998. We have a database of over 5 billion patient records. We collect data on about 100 million lives a year on 72,000 conditions. And part of what we're doing is we know that 70% of African Americans live in 2,500 out of 38,000 zip codes. The same is true for Hispanics. About 70% live in 2,500 zip codes. In the Asian population, it's about 50% in 1,500 zip codes. So we're collecting all kinds of data, and part of what we hope to accomplish is to connect our physician community with data scientists so that you're part of this augmented intelligence, this revolution that's going on in communications. We have to make sure that we're relevant and we are contributing to a really important set of changes. We will not be able to do it alone because it's expensive to do. It requires real skills. And we're also, you end up competing with others who are looking for smart data engineers and statisticians and all the like. So I'm saying this to you, and you'll hear it over and over again from us over the coming months. We have to collaborate. We have to make sure that the needs of our community, it's not that we're just being serviced, but that we're creating that future. I mean, that's probably the most important message I would leave you with, that as we get deeper into the 21st century, we have to make sure that the society that gets built is reflective of our aspirations and goals. And so that's part of what we're thinking about from the National Minority Quality Forum standpoint.
Thank you, Dr. Puckrein. Dr. Andrade?
So that was the perfect transition to me. I am one of those people that's stepping up and shaping the future. So in my role at Philips, I'm a director of product management for our Health Suite digital platform. So I'm part of crafting the vision for our health data platform from the ground up. And what got me here was actually another personal experience. I am a clinician, I'm an academic, and I also switched over and became a techie. But what prompted that transition was my son's life being saved by an ultrasound machine, where it was that transition from being just another miscarriage to an ultrasound finding a heartbeat at a late stage and me having an option to choose to save a life. And that's propelled me into technology. I learned to code while I was on bed rest and then jumped right into the field, have since gone back to school a couple times to get all of the structured thinking and credentials, but it's a passion that drives my life. So you've actually segued really nicely into what we're doing at Philips. So as a healthcare technology company, Philips has the mission to improve 3 billion lives by 2030. And when you think about a mission of that scale, that makes you look at healthcare through a different lens. And so we see healthcare as this massive ecosystem, which is really complex, that's filled with data from different sources, different software, different devices, different technologies, different people, different health systems, and they don't talk to each other and they don't work together. And so we're positioning ourselves and thinking of ourselves as the glue in that ecosystem. And so my job is building our healthcare data platform. We're creating with the Health Suite digital platform and our other platforms technical building blocks that allow you to connect devices from anyone and anywhere, to connect data from all of these sources that you're talking about and more, and exchange them, to connect technologies across the health continuum, and to connect people. And so what you can see is that actually shifts the dialogue and the perspective in healthcare. Because we use those building blocks to build a full range of solutions that can help people who are not typically served, And by allowing and inviting our partners in the rest of healthcare to also use our building blocks, what it allows is for a whole portfolio of solutions and technologies in healthcare that talk to each other. And so we don't get these silos of data. We actually have complete data that we can use to change models of care delivery and to be able to actually start leveling the playing field. So I'm really excited about talking about the different ways in which not only Philips really champions diversity and inclusion so that folks like me can sit at the table and set the menu in the restaurant, even more so, but also so that we can bring the much needed technology and care to populations that don't typically get serviced in the way that they should.
Thank you.
Thank you.
Dr. Abramson?
Thank you. So good morning, first off. I'm Murray Abramson. I'm a physician. I'm very proud to represent Biogen, which is a pharmaceutical company in the space of neurology, bringing important therapies to all patients. I have to tell you, I grew up in Durham, North Carolina, and was the first in my family to both to go to college as well as to medical school. And the lessons of life told me that humanity and human beings are so precious. And it was my goal at a very young age that I wanted to do as much as possible to bring therapies and cures to people in need. And I'm so fortunate to be representing Biogen because it's a company that I have grown up in over the past 8 years. And I'm very happy to say that culturally and their mission is very much attuned to my belief system too. I am the head of global clinical operations. What that means is that we execute on clinical trials at Biogen, about 150 or so in the world. We're in about 60 countries. We affect and directly work with 34,000 patients in a year among 4,000 sites. And so for me, it's not just an idea, but it actually is a commitment to be able to provide access to all human beings in the United States and elsewhere who desperately need therapy. Because this issue is way larger than me, I did ask to bring a couple slides, if I could cue them up. I don't have the clicker, so I'll just ask you if we could go to the next slide. The guiding principles for us is that we're interested in ripping down barriers and hurdles. We live in a world of, well, let's just leave it there. The goal, however, is to reduce barriers and provide access to all human beings. And what I hope to do in the next couple minutes is just to show how we're trying to build trust and value and engagement in populations, underserved populations in the United States included, to increase the understanding of their needs and incorporate it into our clinical designs. We'll talk a little bit about some of the ways that the company has done it, and I will even speak a little bit of how we've done it in our clinical trials, and hopefully just provide a little bit of color to the type of things that we do. Next slide, please. One example, actually we'll go one more if you don't mind. It's a build, yeah. Keep on moving forward. Good, thank you. So multiple sclerosis up, MS up, is the goal, one example in which the company has focused on, in which we're trying to improve multiple sclerosis outcomes among multiple populations, racial, ethnic, minority populations in the United States throughout. And we're trying to do this in a multitude of different ways to understand the needs and to educate, to bring data, and to bring communities together to focus on this serious medical problem, multiple sclerosis. Perhaps the best thing I could do is cue up the video for just a minute or two, and it'll tell you a little bit more, and then I'll continue my conversation about how we're making a difference in this space. We're trying to.
The representation of minorities in clinical trials, I would describe it as low participation. The MSUP initiative specifically focuses to better understand the needs of these underserved populations.
You use your imagination.
Trying to understand their disease, their phenotype, their genetic background, and how that may be involved in the disease severity and disease progression.
Part of the suspicion is that MS affects some populations a little bit differently. And what I mean is down at the local level, you'll have a higher prevalence in one community than in another community. And if you're able to pick up those signals for the purposes of making sure that medication are safe and efficacious for individuals when they get it. But even more important, those tiny little differences are signals to researchers about where can we explore to get better outcomes.
Our clinical trials need to reflect the communities in which we actually live, and it needs to reflect the communities that we actually treat. The consequences of underrepresentation in MS clinical trials are that it is very difficult for us to generalize the results. So if only 1% or 2% of minorities are involved in those trials, how do we then say that this treatment is equally as effective in all of these people?
It's important to understand how medicines impact the disease state. And we know from a biology perspective or from a healthcare perspective, we need to understand the impact that medication will have on patients. Each group, has its own unique characteristics, and the more we understand what the impact of that medication is on that specific subpopulation, what we'll find is a better understanding and hopefully a medication that will be suitable for the right patient group.
Thank you. So if we go back to the last slide, I think just to summarize, in the MS space, we have a lot of access issues. We have a lot of education, both internally and externally in the community. And so it's really nice to use the resources of my company and also to use the resources of various advocacy groups on such a noble cause. Because for a very long time, if you mentioned MS, there are many communities that perhaps didn't feel that they were being paid attention to and listened to. We're going to move to another slide, if we can move up a few, and I want to just talk a little bit, let's skip over this one because I think this group in Washington knows this more than I do, and the ways the external environment has influenced and affected the efforts to bring access and advocacy for underserved populations. I'd like to talk a little bit about the Biogen approach in underserved populations for several reasons. One, part of it is within my group, and part of it is related to clinical trials, which I passionately feel about. The protocol design ideas mean that we have to design populations with cohorts that reflect the actual population for all the reasons that you know, but it doesn't happen just by itself. It takes energy and effort and cultural energy inside the company to push that. Also, the concepts of using the volunteer experience more effectively. Everybody thinks differently about different things, and it's particularly important to listen, to in a humble, thoughtful way, to gather people together and talk about their experience with a disease, without the disease, family members, and to incorporate that in the way we design our clinical trials. Technology has an opportunity to advance it. We were talking about a few. One of the areas that I'm most passionate about is the virtual clinical trial, and I'll talk about that in just a minute. And then other innovative partnerships. Along the end, I won't go through for the lack of time, but there are multiple engagements that we want to participate in various events, and listen. More than talk, listen, because that's where the real lessons are, and we can incorporate that into our trials. Next slide. And this is my last slide, is the way and the opportunity we have to move and transform this space. I personally view, and I know that my group and my company represents this concept of a moral imperative. We are working in diseases such as ALS and Alzheimer's, Parkinson's disease, and other terrible, terrible diseases. And everybody needs access to this opportunity. There are not adequate therapies today for these diseases. And therefore, if you're unfortunate and have a family member, a friend, or yourself with ALS, many times the only therapy that exists is the experimental therapy. And so if we don't make ourselves available and access people wherever they are with this problem, we're essentially not allowing them to have options and hope. And so even though clinical trials can sound very mechanical, it's also critically important because we fit into this moral imperative. Biogen in their multiple programs fits and supports this effort too. So I'm very honored to be here again, and thank you so much.
Thank you. And thanks to our panel for sort of giving us a framework for what their perspectives are based on their current experiences and current places of employment. So let's jump in with a broad question that I want to pose to anyone who sees fit to answer. Over the past several years, and including within this conference itself, we've had a lot of discussions on the Affordable Care Act and the way that that's sort of aimed to reshape the way healthcare is provided within this country. A larger focus on population health and understanding what that population now looks like. So from your perspectives, based on where you sit now, what are some of the biggest either policy or technology barriers to ensure that healthcare is able to embrace those technologies that are innovated and created with a foundation of diversity and inclusion to ensure that underserved or disparate populations are able to take advantage of those newly formed creations?
Sure. I'll kick us off because that's something that I spend a lot of time thinking about. So from my point of view, one of the biggest barriers that we see to being able to make care equal for all is just that whole notion of interoperability. If we break it down, the fact that all of the EMRs and electronic health records and devices and all of the technology, the information that comes from the trials actually can't be combined, robs us of a consistent view of an information's health across their whole lifetime. So if you think about it, we may see a physician in this setting, we go to the ER, in another setting we have another admission for something else, but actually that information doesn't get stitched together because it lives in different silos. That makes it hard to have innovations like artificial intelligence, all of those innovations that build on the assumption that we have a complete patient record and that it's accurate. And then the other thing that when you flip that around, who does that disadvantage the most? Well, it disadvantages minorities who tend to have really fragmented care. They don't have that nice, tidy healthcare continuum of, I have my GP has his or her electronic health records, I go to only facilities within my network. Their care is fragmented anywhere. It could be an ER visit here, a health worker documenting something, and then we actually never have complete information on that individual. We can't make the right clinical choices. We can't use things like population health management to try to decide who needs care because we actually don't have the information. So I think it speaks to what you were talking about as well. So having that cooperation and these common building blocks, the plumbing that we all share among our companies to pool that data and help us work together, I think is going to be one of the key pieces. And you think, but that's so technical, but it actually is kind of the linchpin of creating equality and equal care for minorities.
Yes.
Thanks, Crystal. On this issue of interoperability and connecting the systems, it was my experience also as a patient. I'll just give you one quick example. I was in between the two transplants. I had an episode of septic shock. I had a hospital-acquired infection, went right to the brink of death. In fact, when my wife got to the hospital, they said to Gwen, if he lives through the night, we'll come up with a plan. I got transferred to another hospital after about a couple of weeks. I have some good stories. And then they said, you might have 2 weeks to live, but we can't start treatment until we get the information from the last place you were in. And so then the clock's running and Gwen has to go get the information. So that kind of, much like CK said, that's creates not only stress for the patient, it's unfortunate where the system is now working against you instead of for you. So a couple of thoughts I have, I was thinking of Congresswoman Kelly and others that are involved politically. I've got two policy things I want to address. One is healthcare.gov, the Affordable Care Act. And the second one I want to start with is around this interoperability notion, where the information exists, we just don't have it where we need it when we need it in order to provide, the best care in an equitable way. When in the American Recovery and Reinvestment Act, we incented the private sector hospitals to move towards a digital framework and adopt electronic health records. And so there was a group set up in the government called the Office of the National Coordinator in Health and Human Services. And their intent was to provide this money in return for compliance with you're going to go to a digital framework for delivering care. It was an opportunity maybe missed. And this was to get at how could we connect the systems? Because what happened is everybody solved it in the best way they knew how, but there wasn't a framework to get to a common outcome so we would have interoperable data. So one of the things that we could have done then, and I think we can now, is to make a stipulation of the government funds that flow into the private sector to have a hook with it. And it's that you can have the money if you deliver the data back in a particular format that the government prescribes. And if that were true, then all of the systems coming back would have, we would have interoperability as a byproduct, and we would unlock the data for immense benefit. Examples of this are in the Department of Defense, they're modernizing their clinical infrastructure. It's a once-in-a-generation transformation. The VA is going through the Department of Veterans Affairs is going through the same transformation at the same time. Very unique moment in time. So we're working to connect not only DoD and VA, which has been a challenge for the government and the country, but we're serving in that instance the same constituents, and yet the information doesn't flow. So we're solving for that. The opportunity, though, is in the Department of Defense, about 65% of their spend in healthcare goes to the private sector. What if we made it that if you were a TRICARE provider or you're delivering care on behalf of the Department of Defense beneficiaries, you have to, we're delighted you're participating, but the data has to come back to us in a prescribed format. The VA, with the Mission Act that was recently passed, is doing the same thing. They have about 30% of their care going to the private sector now, and it's growing. And it's never going to shift one side or the other, but there's going to be this collaboration between the federal and the private sector that's so evident. And one of the places that it's evident came out of the prior administration with the Affordable Care Act and healthcare.gov. And where we had a federally funded marketplace to close the gap that we were talking about in the last panel for those that don't have insurance. Well, the technology and the policy created a marketplace for that insurance to be delivered with all the prescribed conditions. But again, we had that opportunity if we could have solved for both interoperability in addition to extending care for those that don't have insurance. So I think there's a couple places where the policy structure, people react to it, and it kind of drives the way that the industry goes. And we tend to want to blame the different pieces of the ecosystem in health when we need to optimize the ecosystem for the good of the whole. So it's just a little bit different look at it, but I think there's great opportunity in policy to drive at some of the things you mentioned.
Yeah, I also want to add about on policy. So as a nephrologist, you know, kidney disease, chronic kidney disease and end-stage kidney disease is a disease of disparity. So, you know, different ethnicities may start off with chronic kidney disease, but if you're an ethnic minority, you're 1.5 times more likely to go into renal failure. And if you're African American, 3 to 4 times more likely to go into renal failure. And about 35% of the dialysis population are African American. And so why is it that for dialysis patients, your care is bundled and there's a cap on reimbursement? So what happens with this is that it drives down the desire for innovation and the funding for research. And you know, when you think about all the other different diseases out there, cancer, et cetera, there is such a disproportion between the amount of money that goes into research for cancer versus nephrology. And I really think that is the biggest barrier.
Thank you.
So in my mind, what's really important as I look across this room, there's an emerging majority coming into the country. It's not just Black and Hispanic, it's Black, Hispanic, white, Asians. We have a new majority coming in. The majority of children in the country today, under the age of 18, are what we used to think of as a minority. So why is Gary Puckrein saying that to you? The reason why I'm saying that to you is, as we start to design our healthcare system to meet this new majority, they're the workforce, they're the business, they are the leadership of the country. I'm going to speak for 2 seconds through the African American lens, just to orient everybody, because sometimes we don't get all these facts correct. So when I look at the African American community historically, from 1619 to 1865, we were slaves. So the best and the brightest in our country, they weren't investing in banks and all that. They were trying to challenge slavery. So when you look at some of the big banks like Solomon Brothers and all of those, they made their money insuring slaves. After slavery in 1865 to 1965, we spent all of our time dealing with segregated America. We couldn't buy a house in certain places. We couldn't own a bank. We couldn't go into the marketplace. I love everybody talking about the free market, but there wasn't any free market for us. So why is Gary Puckrein saying that to you? Because after 1965, we started for the first time to be able to define reality and what we want to shape our community to be. Who do we want to be? What's the community that we want to live in? As we start to think about that, we're also starting with all kinds of disadvantages, right? I hear about Philips, and I love Biogen, and I love this, but the point is, in our community, where does that leave us as they aggregate into this new world, right? Because in effect, we don't own any of that technology. We don't own any of that. And so they're asking our elected leaders to say, help us take the country into the 21st century. And we want to do that. We want to partner and be part of that. But I'm also saying, as we are thinking through that, we need to also understand that we have to build business infrastructure and community as well. Because what we don't want is a lopsided country where all of the resources are aggregated in one part of the country and not another. It ain't going to work that way. It's going to be unstable, right? And so the challenge that you have is, number one, I agree, we got to break down these silos. Data silos in healthcare is expensive, it's foolish, it doesn't make any sense, and so we need to open it up. But it's also part of that larger question that befuddles America right now is, how do we deal with this emerging majority, and what does it mean? I hear some politicians say reparations and others say this and that, but the point of the matter is, it's a very, very deep conversation that has to be understood carefully, because what we want to make sure is that when we come out the other side, we come out with a middle-class democracy where everyone is equal, has a fair shot, and that the imbalances that are historic to this country don't get transferred into the future. And I think that's what you guys need to think about as we work through all of this. It's a very, very deep challenge, but I think that's where we are.
Thank you. Did you have a comment?
It's hard to add to what's already been discussed, but maybe I'll take a very macro view and make it into a micro view to answer just from my perspective some of the exciting things that I do see on the horizon, bringing people more inclusive into solving medical problems and less exclusive. As some of the, I love contemporary art as one of my, I love to read about it. Cameron Rowland is a phenomenal artist. If you haven't read him, I would highly recommend seeing him. The issues that we've addressed here are very much worked within his body of art. But moving on to clinical trials, I think it's probably worth saying that people, if you're diagnosed with ALS in the United States today, it's very likely, depending on where you live in the United States and what community you are a part of, you most likely will not get diagnosed very rapidly. This is a disease that will kill you, on average, within 3 to 4 years. There are people who die within 12 months or less, and there are some who live longer. So this isn't just a hypothetical. This is, how can we build an immediate system to meet this immediate need. It is no different than the AIDS crisis was in the 1980s, to build a therapy to help a group of individuals who desperately need it. And so what we're trying to do is, as we develop our clinical development plans that help us develop our drugs that can take years, 10, 12 plus years to do, within a very heavily regulated environment for the safety and for the efficacy and the best interest of patients, we have to be able to accelerate things. At the same time, we have to be able to listen to all populations to break down hurdles, to get access to people, to allow them to be included where it matters. This is not an easy task. I can say that the team back at Biogen and where our commitments lie is we're really willing to listen, use data, and put ourselves into various communities to be able to better design these clinical trials, not for just scientific purposes and not merely for medical purposes, but for the purpose of saving lives. It's true, there's a lot of money that companies make in this space. I can't change that. But what I can say is the resources that go into this is substantial, and to use it for good is really quite powerful. So for me, what I represent to the panel is really trying to bring that perspective both to my company as well as to the clinical trials, and treating human beings as human beings, treating them as they need, realizing that if they can't get to their clinical trial site, it's just as if you're denying them the therapy. So we need to fly people to places in communities which aren't available. And this is where one of the more exciting transformations I will see in the next few years, will the concept of transforming us into a virtual clinical trial. So that if you happen to be living in one community or the other, and your institution doesn't provide you this therapy, you should have access to the information in a transparent way and access to the therapies that are being worked on for your betterment and your family's betterment. And that's just from my perspective.
Thank you.
If I may, I'd like to piggyback on your comment about building the community and strengthening it. Companies like Philips are also part of communities. And I think about all of the initiatives that we have that drive us, that encourage us, that make us committed to participating in building the communities that we serve. When we think about how will we change the democracy and the shape of the future of the new majority, well, it becomes things that are as basic as, how do we get more people from minorities into STEM? You know, the comment yesterday about the paucity of Black doctors is very similar to how utterly lonely it is to be a woman of color in engineering, when we look at the fact that all of Hispanics, Blacks, are grossly underrepresented. So looking at efforts from my colleagues within Philips of doing things like volunteering in communities to mentor and encourage people, kids, to have role models in STEM, to aspire to be in sciences and in engineering, that partnership with Philips and the communities is part, actually, of helping to build the community and make it stronger. But also the community is a big part of our voice, where it's not only just our volunteer work, but also making sure that in all of our design efforts and all of our work, that it is inclusive in the community. But I think you raise an important perspective of how do we balance it all.
Excellent. Is there any final comment from one of the panelists on this question? Okay. So I'd like to dig in a little bit deeper on some of the topics that you all have brought up individually, but I also want to make sure that the audience is engaged, because I see a lot of eyeballs and rapt attention and note-taking. So I'd like to invite you all to start queuing up at the microphones, and we'll do a little bit of ping pong. So I will queue up a question for one of the panelists and then invite someone from the audience to pose a question afterwards, and we'll just go back and forth like that to make sure that you all have ample time to ask the questions that are burning their way through your spirits right now, okay? So I'll pose the first question to Ha. So you noted that ESRD is very much a disease of disparity. And you've also indicated that Baxter has done a pretty good job in their clinical trials of making sure that it was structured in such a way that the trial population echoed the population of people who would ultimately be receiving therapy.
Correct.
In what way do you see D&I as a motivating factor in that? Was that a conscious decision that was made? Was that a part of cultural shift? Was there some sort of quickening moment that made it sort of apparent that that's what needed to happen to make sure that the trial was robust and reliable and applicable to the population that it was ultimately going to serve?
Thanks for the question. Yes, so I think D&I is a part of everything that we do, and it really came into fruition maybe the past couple of years when we had a new CEO who came in and said, we need to focus on innovation. So we need to, reframe how we think and how we research things and how we develop our programs and how we run our trials and how we launch. And so I think starting out, we know that there are different forms of dialysis. So there's hemodialysis, there's peritoneal dialysis. So hemodialysis is when you have a catheter that's inserted or into your bloodstream, and you can have in-center dialysis where you run in clinics or centers, especially for that. Or there's home hemodialysis as well. And then there's peritoneal dialysis, and that is where you put solutions into your peritoneal space in your abdomen, and that is a therapy that's done at home. And lastly, there's expanded hemodialysis, which is a whole new class of therapy that is in development. But I really wanted to focus on the fact that for home dialysis programs, that is something that is for underrepresented minorities or underrepresented population. You're about 30% less likely to utilize these home therapies. And so, what we did is we really looked to see how can we change that. And so we looked into most of these patient populations, they live in either urban areas or rural areas where spacing for your supplies are limited. Not everybody has a 5-bedroom, 4-bathroom house and a special basement and storage room where they could keep all of their dialysis supplies. So, we have a molecule in development where we looked into how about we can generate your own dialysis solutions in your home. And, with that, we thought about all of our study teams. What's different about Baxter is that it's not just members who have been in drug development for 20 years or so who are running these study teams. We have clinical nurses who have never been a part of a clinical trial before. We have engineers, we have physicians, and we also have the service technicians, the ones who actually go to the patient's home, who sit on our study teams, because they're the ones who interface with the patients, and they come and they bring the feedback right back. And we also have a program called a ride-along at Baxter where any employee can sign up and go with the delivery person to the delivery trucks into the patient's home and see how these patients live and what requirements that they are under and what challenges that they face when they don't have enough space for their supplies, when they have to share their space and things may not be sterile. And so we think through all those things in our process.
Excellent. So I see we have someone here queued up. Sir, if you would please give us your name,
Sure.
your organization, and your question.
It's more of a comment. It's for Gary. I've known Gary a long time. Anyway, Rick Blake, the Institute for Family, a very long time. Okay, Gary. At the Institute for Family Health in New York, we're the largest network of federally qualified health centers in New York State. We have 1 million patient visits a year. We have both urban and rural health care centers. We're in schools, blah, blah, blah. So I wanted to, Gary offered a challenge that I didn't want it to get lost, which was a challenge of cooperating to develop a possible, let's call it a field study, if you will, but it doesn't have to be that small, The Institute would be happy to work with you, Gary, on that. We have the EPIC system, so we've kept records since the mid-1990s in terms of patient health care. And I unfortunately also suffered through the national health policy debates on the architectural framework in the nation. It was set up by, it was set up by Bush and then came to Obama. And then, well, it still exists, but it's a lot less than it was during the Obama administration. So we have ways of anesthetizing our databases, but at the end of the day, I still want to say that we provide health care. 68% of our patient population is Medicaid, and maybe 70-something% is either Black or Latino. So I wanted to work with you, Gary, to get something going here, and if it's a grant, it's a grant, whatever it is. You know me, man. But I guess my question for the panel is, I wanted to take it to a less theoretical level, because we're talking about, and Gary did that. I mean, he has the history of connecting the history of African Americans with healthcare, and there are very few people who can do that. There's some, but very few people can do that. We cannot deracialize our conversation, and we can't take it out of the context of the segregation of what our people has suffered. So I think, corporations are okay, but they have stockholders. They have to make profit. There's nothing wrong with that. I'm a market guy, but I'm just saying we have to put this in the context of what Gary spoke about in terms of the history of African Americans. And remember, that's not too long ago. We're talking about racial segregation of hospitals. Well, in a sense, while we've moved past some of that, we're going back towards it with the cost of care, and then the amount of care that falls back on federally qualified health centers is enormous. So I think we need to realize that while we're all talking about innovation and technology, what are we going to use it for? How much is it going to cost? And then how is it going to afford to Medicaid patients? How is that going to happen?
So I'd like to address that point real quick. Thank you for that. So I want to let you know, to follow up on my previous comment. So when we do our investigations before we look to go test a product, we do look at, how much is this going to cost in the home dialysis programs. We look how much is this going to cost in electricity per month? How much more will it cost, or how much? And then we look at how much in water usage as well. So I understand what you're saying, and when our targeted therapy is also very selected towards certain populations, because we know there are certain populations that are more at risk for cardiovascular disease, and so we looked to develop a dialyzer which actually clears molecules that add to this inflammation or these cardiovascular events. So these do really, we do take all these things into consideration. And as I said again, kidney disease is a disease of disparities just by nature of it. And so this is at the heart of what we do. But thank you very much.
Yes.
I want to address the question in the sense that a lot of companies may look at underserved populations maybe from a marketing opportunity. It's inevitable. I can say that from my perspective and what I've seen at the executive level, the ideals of inclusiveness and bringing in underrepresented populations into our trials starts with the CEO and actually goes to his executive team, and the activities that we do will be reflected regularly at that level. I don't know if all other companies do that. Some do, some don't. I think that if we merely look at it as an economic problem to fix or an opportunity to make profit, you miss the bigger issue. And I think that's one of the points that I heard. And I think that there are multiple things that we can talk about in that space to not be able to make up for the lost history, but to at least try to establish and do something different and better going into the future.
Go ahead.
Yeah, I was just going to ask, answer this way. So the Robert Wood Johnson Foundation created a program for hospitals. It was called Anchor Institutions. And basically what it was saying to hospitals is that you're really an anchor institution in a community. So you're just more than taking care of sick people. You're an employer. You're a contractor. You contract out for a whole host of services. And you bring real stability in the community. And one of the things that I find incredibly interesting these days is how we're closing down rural hospitals, which is probably the largest employer in the community. I find that kind of interesting. But nonetheless, the point I'm making is, I think that model and framework is good for any industry to think about, particularly when you're approaching diverse populations where there's all this legacy and need to bring those communities along. You can be an anchor institution that obviously taking care of their health needs is really important, but employing them, helping them to get educated, contracting with them. I mean, you have to have this broader sense. And I think that's where government can play a really interesting role. I know Congresswoman Christensen did some really interesting work that didn't get through Congress, but that Maryland did when they created health disparity zones and offered all kinds of tax incentives and things like that to stimulate. So there's a lot of ways to think through this, but we first got to recognize that there's something to think through. And that's, I think that's the point that we're both making. But sorry.
CK. Oh, sorry. We'll get right to you. Yeah. You had a comment?
Yes, I wanted to actually sort of bridge between those two and respond to that excellent question in the comment. So at Philips, the reason that I ended up going there after Silicon Valley and a host of other companies is because our mission is to improve 3 billion lives, and our vision is meaningful innovation. And they take that seriously, where being able to serve individuals, to be able to create technologies that get to the people who are not getting care is part of our DNA. And so it's looking at the way in which our innovation comes from so many partnerships with community facilities, with people who are actually grassroots in the field, who we partner with to develop innovation, try it out, and then bring it back in. And also looking at the ways in which we actively communicate with the government. Using that as a way of informing what our priorities need to be and having that two-way dialogue so that we focus on things that are relevant to the communities and not that pie-in-the-sky ivory tower, let's make something because we can just make a ton of money at this. And so for me, it's important that, as you mentioned, whether it's these different programs that we've all been talking about that tie us very closely to what the needs of the communities are and help to build them and give back.
Thank you for the opportunity. Mejia Indom, I'm one of the 40 Under 40 awardees. I'm actually at the National Institutes of Health. I'm not representing the National Institutes of Health with these comments. I'm a neurosurgeon scientist there. I also serve on the boards of 6 or 7 different organizations for various reasons. Now, some of those organizations, I think, went out to find me because of who I am and my particular background, and that being different from the boards that I'm on. And some of them, I think, got lucky just because I fought my way to the top of whatever organization I was working on. I'm the first African-American chair of the Young Neurosurgeons Committee of the American Association of Neurological Surgeons. That's one of the organizations I think got lucky. I just happened to fight my way to the top of the Young Neurosurgeons Committee. Now I'm on the board, and so they have to listen to me as a diverse individual. But then there are others like the National Brain Tumor Society where an African-American member of the board went out to look for more to kind of amplify the voice. And where I'm going with this is something I asked some of the patient advocates earlier. I think the initiatives that many of you have spoken about the way you're trying to bring diversity into things that you do, the patients that you're serving, the people that are involved in making some of these decisions and doing the work, and I think that's phenomenal. But the question I have is what are these companies doing to bring diversity into the C-suite, into the board of directors? I think that if you have an innovative and driving CEO, then oftentimes diversity will become part of the work that you do because it's important for the work that you do to be valid and for the trials to be valid and for them to apply to the most people that they can be. And again, it's phenomenally important. I think you're doing great work that way. I would question if you don't specifically have initiatives that are also trying to improve the diversity at that leadership level, then there are opportunities that are going to be missed. And it has to be an active process. I mean, we've talked a lot about pipeline and increasing the diverse workforce. And when we increase the diverse workforce over time with these vital pipeline activities, then more companies and organizations will get lucky because more of us will fight our way to the top and will become parts of these organizations. But there are many of us out there right now who could serve in those capacities who maybe aren't being asked because there isn't a concerted effort to increase the diversity at that level. So I would just like to ask if that's something that your companies are currently undertaking, and if not, if that's something that you would consider going forward.
Thank you.
I'll jump in. On behalf of Accenture, we are one of the most diverse companies, recognized globally as one of the most diverse and inclusive companies in the world, and are very intentional at all levels of the business. In fact, one of the things, we have a goal for by 2025 to be 50-50 gender diverse. And I'm kind of, I understand your question. I'm just delighted that I work in a place that has that kind of not only vision, but action. And I wanted to add a little bit of color to the commentary as well. I think about the conversation we're having, even in the last couple of hours, and there's a sense of, well, if industry was different, healthcare could be different, and disparities might be less. And you're sitting in industry and you're like, my gosh, if we could just get the government to do. And then when you're in pharma, you're saying, those insurance guys, if we could just get those insurance. And so we end up pointing to another part of the problem, and we really have to find a different way to have the conversation. These pieces of the ecosystem exist for a reason, and we have to figure out how to optimize them. And sometimes the scale of it is so significant, you're kind of caught, like, well, what could we do? And it just feels overwhelming. I want to tell a personal story, and I don't want it to be misinterpreted, or there's no sense of bravado here. This is just what happened. Because I was sick, I was over in Parliament and got directed into a group that was doing a foundation to try to get healthcare into Africa and leverage the cellular infrastructure to deliver care for those that don't have any. But in Africa, everybody has a phone, or an amazing number of people have phones that you wouldn't imagine. And so we were exploring this possibility. And we had this similar conversation, and the chairman of this foundation was Archbishop Desmond Tutu. And we were talking about this, and he said, you know what? We keep trying to solve it. We're kind of stuck until we come up with an answer that we can go run at the problem. He says, we have to stop doing it that way. We need to do as much as we can for as many as we can, as fast as we can. And then allow the solutions to emerge because we're engaged in solving the problem. And I really commend Gary and the team. One of the things, this will be my last point about Accenture. One of the things we did, we went into, there's a physician in Harlem, and I'm sure you know Dr. Freeman, who set up a patient navigation system for folks that have cancer, but are in the underserved communities. Well, how do they get help? And what we're able to find is by training, and Accenture had put a significant amount of money, not only to this community, but also into others like Cleveland and around the country, a significant amount of money to train up these patient navigators to help the underserved get access to care where they normally wouldn't. And we've seen tremendous improvements in care. For example, one statistic, breast cancer went from only 39% getting the care they need to actually recover and continue on, and that went up to 70%. And so we're seeing, that's something we could uniquely do. We engage, we train others, and that would be enduring long after we're gone. And so that's the kind of thing where I would say diversity, inclusion, being intentional, solve for what you can as fast as you can, even if you can't solve the whole thing at once.
I think on behalf of Baxter, I think I have very concrete examples on how the leadership is doing. So my Chief Scientific Officer. His name is Sumant. He's South Asian, incredible person. And then even myself, I'm on the global leadership team as well. My name is Tran. It's not very easy to say. We also have a mentoring program. So every director level female is paired with a female in leadership, such as a VP level, to get the mentoring to try to get to that next step. They also are very, I'm not a D&I expert, but I know they have a lot of other programs as well. But I think like when you take a look at your board and you take a look at your senior leaders and you see the diversity up in there, I think that speaks a lot. Speaking about last night when Dr. Stanford had talked about like being in that environment and growing up in Atlanta where, she would see African-American physicians. So she knew that this is something that she could do when she grew up. And I think I feel that way in my career as well. It's like when you see leaders that, look like you or look different, it helps as well.
Okay, CK and Marie.
So thanks for that question. So I am where I am because of Philip's diversity and inclusion commitment. So when we look at some of our activities at different levels, so I think about so I'm in the Senior Women's Leadership Program, where they have actually defined what percentage of our senior leaders within the organization are going to be women by a certain point of time. And it's women of any color, and that we're all mentored and groomed and given opportunities to move up. But there's also a huge focus on inclusion at Philips, where it's not just about checking off numbers, but making inclusion a way of being. And that's how we feel about it at Philips. It's a way of being, not a program, not something that you go to a class for. And when I look at the training on unconscious bias, well, it starts with our C-suite and pushes its way down into the organization. And I was really proud when when our chief technology officers in Philips, like one of our higher level IT people is Michael McNeil, who's Black, being able to start looking at ways in which we actually push people up. And as you were talking about all the mentoring, a lot of not only mentoring individually, a lot of grassroots communities that are supported by our C-suite to be able to help people and not just diversity for color, diversity for gender, diversity for orientation, diversity in all ways, to have a safe, welcoming space in the company where they're heard. So I think there's a lot to be done, but when we have our highest levels bringing people up, I think it's really important.
Murray, I'll let you close this out.
I'm sorry.
I'll let you close this out.
Okay,
And
I'll make it very brief. I want to thank you for the question as well. I will just add to the sentiments that have been shared by the committee, or by the folks up here. I would say that for my company, it starts at the C-suite as well, both in creating a diverse environment in that space, and then through multiple internal and external community programs to bring people into the organization in inclusiveness. I'm proud to say that there are multiple awards that the company has won for its place to work in a diverse population, whether it be gender, orientation, race, ethnicity. That's true, and I see that in multiple different ways. I'm also proud to say that the Biogen Foundation, which supports a huge mission, includes STEM education in the underrepresented populations of the United States, and for that matter of the world as well, where they spend tremendous amounts of money to ensure that people have opportunities to go into science and math and engineering and technology, not merely for a company reason, but because it's the right thing to do in the community. And because we have such strength in our communities, both in North Carolina and Massachusetts, a fair bit of our resources go into that space, both from networking and bringing people into mentor. Alizar, I think, may be out here somewhere. Oh, there you are, Alizar. Good to see you. He represents, of course, the lab community within the Cambridge, Massachusetts area, but we also have such in North Carolina. And it's just a phenomenal opportunity to engage young minds and bring them into the wonderments of medicine and science and engineering, who might not otherwise, given where they sit within their community, would have that opportunity. So there are multiple different things, and I really appreciate that question.
Thank you.
So good morning, and I'll keep my question brief. I'm Marjorie Rollins, Vice President and Chief Scientific Officer for the PCPI Foundation in Chicago, Illinois. We focus on improving performance improvement and quality improvement through measurement, clinical registries, and we have a quality improvement program. My question is to the panelist from Accenture. I apologize, I don't remember your name, but I spent an incredible, this is about your comments on interoperability. And I spent about 5 to 7 years on various ONC panels, task forces, et cetera, to help interoperability move forward. CMS has now moved those into their quality payment program, some of those efforts. But we still haven't demonstrated quality through interoperability. And I'd like to know what you believe are the next steps for that.
There's another group in Chicago too, and I just couldn't hear your organization. Could you just repeat it?
The physician, it's PCPI Foundation, formerly known as the Physician Consortium for Performance Improvement. Okay. We are part of the AMA.
Yeah. There's a number of groups like this that look at data in healthcare, and there's another place in Chicago, the name is going to come to me in a second, where 110 medical academic centers, including the Department of Defense, put their data into this shared database so they could do comparative analysis for quality purposes. And what they're able to find, for example, is let's say that Cleveland Clinic has 5 cardiac physicians. 2 of them have a very good outcome in that shorter time in the hospital, and they're not coming back in once they're discharged. And so what that allows the rest of the participants to do is to look at that capability, not only to benefit the other 3 that serve in the Cleveland Clinic, but others that are in that practice to improve the delivery of care and improve the quality. And as a country, obviously, we have to get all of that right, the cost, the quality, and the access. And so that's a very important component, but it's data-driven. The other thing it allows is executives that are working in health systems to know what to focus on next to get the greatest benefit in terms of being able to drive quality, because the data begins to expose where the opportunities lie. I don't know if that's helpful, but with a brief amount of time, that's...
We'll talk after that.
Yeah, I'll look forward to it. Yeah, thanks for asking.
So, last comment?
I'd like to briefly add to that. So thanks for that question. I just want to blow up the definition of interoperability a bit, because too often we have a very narrow view of interoperability and we only think of it as, oh, well, we want all our data in one format. Interoperability means that you can connect devices and different technologies and different systems all the way across the continuum, no matter who owns it. And that drives quality, and I think about some concrete ways at Philips. So for example, we use our Health Suite digital platform, our cloud platform, to be able to drive telehealth. We've done some studies with a large number of facilities, for example, looking at our work with Banner, where you can use interoperability in this broader sense to actually decrease readmissions, decrease cost of care, decrease mortality rates. So there is actually a really concrete relationship between that broader understanding of interoperability that things like health platforms and standards bring us that actually changes the quality of care in really concrete ways.
That's a great point.
Yeah.
So we're just about at time, but I don't want to close this panel out without some parting thoughts from our guests. So in 1 or 2 sentences, how do you envision diversity and inclusion in shaping the future of technology innovation within the healthcare space? Murray, we'll start with you.
Oh, well, first, thank you very much. I think that there's a lot of work to be done. Persistence, grit, and determination are important ingredients to that. And it's a path that we're on together, and I'm very happy to be here.
CK.
Well, for me, it's been an absolute treat being here with an esteemed panel. My closing thoughts. We are our own best advocates, and that intersects with, if you can't see it, you can't be it. So bringing people along, allowing, not only being a role model, but encouraging someone to take an interest. And it doesn't have to be STEM, but bring them into getting the education, getting the skills to be able to be part of shaping healthcare and health technology.
Gary.
Yeah, so I'll end where I began. You're in a unique place now, and these seemingly technical questions like interoperability or talk about a number of different states, they all have implications for our community. And I encourage you to think about that, particularly those who are in policy, either in the executive branch or in the legislative branch or down at the state level, that it's easy just to say, oh, we're having a narrow conversation, but that conversation actually has broad implications for our community. And so I think as you go about doing what you do, just keep that framework in mind.
I think most of us in this room are leaders, so I really want to advocate for intentional inclusion. So go seek out and go question those that you may not think would have the answers, and that starts from, everyone from the bottom of the team, and just really no ideas are bad ideas, and just take them and listen to them and really consider them.
And last but not least.
Yeah, thanks. Thank you for leading us. You did a great job. Really appreciate it. Yeah, and I was at the Board of Trade, U.S. Board of Trade last week, and we were looking at a smart region for D.C., Maryland, and Virginia. One of the stories that emerged was in the inner city D.C., the student athletes get back on the bus after practice to go over so they could be near McDonald's and get on the Wi-Fi to do their homework. That's like unbelievable. And the intent was, how do we roll out a smart region? And my focus was, how could we create more equitable access to care? And I think it's by inverting the model, where it's not, will the doctor see me, it's, do I need to be seen, and the patient getting to decide it. We close part of the digital divide, one of the actions of the Board of Trade. Then we begin to open up, at least in this immediate region, and again, let's do as much as we can, as fast as we can, for as many as we can, and taking those next steps so that we can get equitable access.
Perfect. And on that note, I want to thank our panelists for being here with us today and sharing their considerable brain power.
Thank you.
And also like to thank our audience for your attention.